So again, good morning, everybody. I'm Yvon Baribeau, and I will be presenting a little bit of our experience on a drain technology that allows better drainage. Just to tell you a little bit about me. I'm a cardiovascular surgeon, thoracic, boarded in vascular and cardiac, who works at. We are the largest in volume cardiac surgery center in the state of New Hampshire, which is obviously not that big, but we love it. Just to give you an approximate idea, we do about 650 hearts a year. We're three surgeons. We do about 180 thoracic procedure, major, and we do about 600 vascular procedure a year. So we are a busy center. We live in the real world. We do not do kits, and we do not do transplant. We do assist device. So this is in collaboration with my partner, Ben Westbrook, and Louis Perrault from Montreal Heart, Simon from Mayo, and Ed Boyle is the smart guy who started the technology. I'll talk to you a bit more about it in a second. Let's get started. We have some disclosure that the company paid for the different research people we had putting out the numbers for us. Well, we all know as a surgeon that when we operate in the chest, particularly on the cardiac side of things, that you better get the blood out very quickly and efficiently. Otherwise, you have mostly problem compression or ongoing bleeding. So the standard way of doing this, as we all know again, and I'm sorry if I repeat myself a bit, but it's with chest tubes. And sometimes you have good days, the drainage is slow, and we can manage things very easily, or sometimes we're called back at night because it's really continuously bleeding. Again, what we worry about in the case of cardiac surgery is the volume or mass effect of the blood accumulating itself outside of the vicious circle. I'll talk to you a bit about that in a second. Now, again, we all use conventional chest tubes for the most part in our training, and we all know that about a third of them get occluded, obstructed, and we all have been reoperating these patients usually at 3 a.m. and finding chest tubes that are just like you see on that pictures, that are with eyelets that are totally occluded, and a lot of times we'll find the clotted blood outside the chest tube itself. The pathophysiology of these obstruction is pretty simple. We all understand it, but once you start clotting your chest tube, the blood in the mediastinum will not drain to these same eyelets, and you start creating that clot initially somewhat around the tip and then around the whole eyelet area. And this clot is outside the chest tube. So even if you milk or even suction those chest tubes, you're not efficiently draining the mediastinum for the simple fact that the eyelets are occluded from the retained blood. So this retained blood is the big deal. I mean, that's why we're impressed with our study, is that we know, and that's been studied very well in the lab, that once you get blood in your mediastinum, and that then you create these different reaction, including the white cell that will create some kind of an inflammation area or milieu, and we believe that this is a big part of the reduction in the atrial fibrillation incidents that we see in our patient. And again, if you go back in the past, the infusion of blood in the pericardium was an experimental technique to create AFib in the animal. So bad thing to have retained blood in the mediastinum, to a point that a few years back there is a paper that was published, describing the so-called retained blood syndrome, which basically is a compromise of anything within 30 days that includes re-up bleeding, when you cannot close the chest because you have ongoing bleeding in front of you, any lung pleural intervention, usually by thoracentesis or percutaneously, and sometimes VATS, and we do see these cases. I'm sure people know that. And as well, pericardial intervention, would that be a post-op 7 percutaneous pericardiocentesis, or even sometimes windows. Now, the smart thing about this chest tube is it's actively draining the tube itself, and secondarily, you do not accumulate any blood around the eyelets and around the tube itself, so you don't have that mediastinal milieu that we just talked a minute ago that creates all this inflammation and basically brings you trouble. As you can see, there are pretty much a normal appearing chest tube, but inside there's that magnetic drive loop that allows the nursing people to actively pull in and out in a sterile fashion and clean the tube outside all the time. And again, you do not want to accumulate anything outside. We all have seen that picture, usually again at 3 a.m, that you're wondering how come he stopped bleeding and his pressure is down and you have an issue. And again, once you get your tubes clotted, you can't do much about it. Even if you clean the tube, the eyelets is the trick, and this technology allows you to always clear those same areas so you don't accumulate that clot inside the chest tube. And again, that there are studies showing that milking is bad, but we've all done it. This is what you do. You try to milk something, but if you look on the slide on the left side, you can't do anything about what's happening around the chest tube and through the eyelets. So the chest tube is basically not functional. While the ACT technology or the active clearance technology allows the nurse to actively keep the drain active and mostly functional, in that you don't accumulate any clot around the distal part of the drain. There are some company actuation schedule, they call it, whereby the nurse will activate the chest tube at different time. To be honest with you, what we've done in our learning curve, which is I think the secret of having a successful program using these tools, is you have to train the nursing staff very, very precisely how you want to handle it. And that's probably key to it. By the way, the company is extraordinary because they have a very, very efficient support. They'll send you the people to train your ICU people. Basically, what we do in our case is there's blood in the tube. The guys, I should say, to be correct, they will actuate the chest tube itself, as you can see on top of the slide, and you just simply pull that back and reintroduce it in maybe 1, 2, or 3 times until basically there's no blood coming out of the chest tube. So we are somewhat aggressive with these chest tube actuation and mostly on a visual input. So our study was basically consisting of 2 surgeons, me and Ben Westbrook, and we pretty much do the same thing all the time. We operate the same way. We have standard protocol that are the same. We took 630 patients. We took 2 group out of this one. The first group where we were doing our regular chest tube technique, and I'll talk to you in a minute, and then a new group that had active clearance technology. But what is you need to know is between those 2 groups there was a few weeks period where everybody was trained correctly because we wanted to be fair to the company. So what we look at our primary endpoint, which is a reduction in the so-called retained blood syndrome, thoracentesis, re-up bleeding, etc. And we also look at the other postoperative complication, including AFib, and look at our outcome, and we actually look at the cost as well. Our standard protocol for Westbrook and I is always the same. On cabbage, we put a clear flow chest tube in the mediastinum and a regular chest tube on the left. This will change imminently because the company has now a new chest tube which is very efficient for the left side, and that despite having the same technology, there's more side holes or eyelets on it. So that's something we're going to be trying soon. And also we do a lot of thoracic, where we have a strong interest in this for empyema patients. We'll talk to you more about it. And again, a 24 in the mediastinum and a 24 on the left pleural. If we do a valve, we'll sometimes use 224 clear flow. Our population that we studied on a 260 patient on each side they were identical, and as you can see, average 66 years old, mostly male. Weight was no difference. Diabetes, hypertension, all these factors were the same. Even the New York Heart Station CHF class was the same. No more patient on a balloon or not. And the medication, which is critical, as you all know, preoperatively, was not any different. We did not have a difference in redo, which I think we all know we do less redo now because cardiologists are better at what they do, and the lipid drugs are working, that we still are around 6-7% redo in our group. And again, there was no difference in the urgency of the patient. The group of the surgeries were about the same. 60% or so were coronary bypass, 12% were valve and combined valve, and coronary bypass was about 13%, with the rest being aortic dissection, multiple valve, etc. Our practice is mostly off-pump practice. We do most of our patients without a heart-lung machine, but again, it's critical that they were equal on that side. And we presented that last year or 2 years ago at an international meeting, but there is a clear advantage even on off-pump patient. Bypass time was again no different. So what are our results? Again, you can see the slide very well, but I think what is striking mostly is that there was a dramatic drop into our pleural intervention, meaning thoracentesis. And again, we do our thoracentesis the same way. I think we evaluate the same patient, me and Dr. Westbrook. So this is really a two-surgeon common practice over 20 years. And you can see we reduced our thoracentesis, and our that was a very impressive result for us, because as you know, that takes time. Even if you have PAs, you got to be around. Other change that we saw, and you can see the p-value, we saw less ICU time, which is critical, as you know, in these days. Less ICU time in hours and days. The vent was less. Intubation was the same. And curiously and interestingly, the volume of blood drain was not really different, but again, I believe this is strongly related to the first few hours and the fact that we do not accumulate the blood around those islets that allows this inflammation milieu in the mediastinum. The renal failure was also less, as well as the infection, mostly, as you can see, less pneumonia, which obviously explains a lot of those longer time spent in the ICU on a respirator. We had more TIA in the pleural flow group, curiously enough, because we had less atrial fibrillation, and that's obviously a big one, because as you can see here, we had a 32% reduction in our atrial fibrillation, which is huge. And again, that may explain as well our lesser postoperative length of stay. As you know, we have to keep these patients in, at least for anticoagulating them, for liability reason as well. So if you don't have AFib, it's much easier to discharge your patient earlier, as well as if you have obviously less ICU time. So pretty impressive result to our amazement. Actually, I was surprised, because I was convinced that we'd have a reduction in the pleural effusion phase, but not really in the atrial fibrillation. And others have shown that same thing. As you can see here, that in our study there was a 32.4 reduction in post-op AFib, which, as we all know, is a big deal, a big problem for us as surgeons. Post-operatively, we delay our discharge quite a bit for the same reason. And more importantly, as well, as you can see at the bottom, we reduce our costs for the same patient. Again, these were case-matched patients, and we spend a lot of time doing the right thing and verify the numbers, but we save about $1,000 on the cost reduction. So again, to repeat myself, less pleural issues, much less atrial fibrillation, which is a big deal. And again, a drop in the length of stay, and as well a drop in the price, which is obviously something you want to show to your administration, and this should be published very soon. But we obviously want to discuss that with the administration, who's always looking how much you're spending where, and then wants to cut everything they can. So for our group, this is a standard of care. Actually, we use these tubes routinely, and now, like I said, we're going to start using that new chest tube technology in the left pleural space. So I hope I convince you that at least give it a shot. But to us, it was very, very convincing. Thank you very much. I have, before I let you guys go, I have two questions that were sent to me a bit in advance. The first one was, what's the most striking evidence for us that they work? I think I presented that. Basically, the most dramatic is the drop in the thoracic pleural effusion incidence, and also the drop in atrial fibrillation. And the fact that the cost is reduced as well is a significant deal, not only for the whole system, but also to be able to deal with your administration, which we all know are the ones that deal with them, that it's an ongoing fight. And once you show them clinical evidence additional to benefit money-wise, they will go with it without any problem. Let me see, there was a second question, guys, on what is our strategy for chest tube. Again, we use a standard clear flow in the anterior mediastinum on the coronary bypass. Most of them have a left pleura that's open. If the pleura is open, we use a 24 regular chest tube. At this point, we pull our drain usually within at 24 hours, sometimes 48 hours. And this was comparable in both groups. Now we have a new device available, like I alluded to earlier. It's called an XDL drain, but basically it's a 24 or 28 French. You can decide. We use 24 everywhere. And it has more eyelets or side holes on it with a longer distance of drainage, 10 inches versus 6 for the other one. So we are seriously looking at this, and also we do a fair amount of thoracic surgery in our group, and we want to look at that also in that sphere, particularly for the ones you worry that they're going to clog their tube quickly by debris, particularly the empyema that you decorticate. So that's about it. Please feel free to send any email you may have. I'll be pleased to answer any question that way. And again, thank you for having me.